Dr. Sushmita has very kindly consented to fill in the gap because Dr. Nangia actually is down with high fever and couldn't make it to the conference at all. Thank you, Sushmita.
Thank you, Chandrama, for having me. And this is sort of a catch-22 question for me because by the end of it, we'll realize that there's no versus, and probably we need both. So, alas, there are no financial disclosures. There's no debate actually. The outline will go through our vital insights for a diagnosis, feasibility, and what is the evidence. So we all know that gonioscopy is the gold standard. Any imaging device that you have is going to be compared to, is it as good as a gonioscopy for angle assessment. So we have the UBM, this was the paradigm, now that's out of manufacturing, so we have the Quantel, which is as good, 50 megahertz. And that's the cirrus OCT with the anterior segment module, but now we have the swept source or the cassia, which gives you 360 degrees, and it has various other advantages for the glaucoma bit as well. So if you talk of the ease, cost and feasibility, the gonioscope would win hands down. There's no comparison between the two, between something which, one of my favorite pictures of a 3-year-old girl, you can do gonioscopies in lots and lots of people. So saying that the patient was not cooperative is more a cover for saying that I didn't have the patience to do it. And the UBM and the cirrus OCT and the anterior segment OCT are there, of course, but if you look at cost and you look at ease to just look at the angle, then obviously the gonioscope would win hands down. So having said that, if you have plateau iris, yes, the UBM would easily tell you that this is a ciliary body knuckle, which is pushing the root of the iris up against the trabecular meshwork. And if you simply do an iridotomy, maybe you will be treating the pupillary block element of it, but if it is chronic angle closure after that, you might require an iridoplasty or something. However, there is a paper which actually looked at gonioscopy versus UBM, which was a double-blinded study, and a double hump sign observed on indentation gonioscopy here was strongly correlated with the presence of a plateau iris on UBM. So that's easy to see why. This is the ciliary body knuckle here, which is indenting it up, and if you on indentation have a double hump sign, it's more likely than not that they are also dealing with a plateau. So a plateau iris configuration can be detected without using a UBM in many cases. So gonioscopy would be indispensable if there is iridotrabecular contact and you want to know whether it's synechial or appositional. Imaging wouldn't give you an answer. So for this closure to tell you that it's appositional by the angle opening up on indentation, imaging is just going to show you a narrow recess, but it's not going to tell you whether it's going to open up or not. What about the utility in trauma or PDS? So this is angle recession and cyclodialysis cleft, demonstrating well on imaging. Yes, you can see the cleft in the longitudinal and circular ciliary muscle, but then it is seen here on gonioscopy as well, and you can see the ciliary body which is there and the iridodialysis as well. PDS, pigment dispersion, pre and post LPI, you can see a nice concave configuration and a flatter iris, very nice and beautiful to show the patient, but what prevents you from showing the same on a good gonio picture? So you can see a pre-op concave and a post-LI flat iris as well. And the question is, how would imaging show a subtle Sampaulosis line in pseudo-exfoliation, or a painted trabecular meshwork in pigment dispersion, or blood in Schlemm's canal in Sturge-Weber, or these broad-based iris processes versus these iris processes in Axenfeld. So the quality of diagnosis by looking at the angle is only possible with a good gonioscopy, and I want that message to go through before we jump on and say we can do without a gonioscope because we have an ASOCT. Other things, how would imaging show these nodules? Now this would show you that it's an angle closure, but if you see these nodules with a pulling up mechanism, that's the only way you could know that it is a Cogan-Rees, a peripheral anterior synechiae in Chandler's syndrome. These are emulsified silicone oil post-PPV glaucoma, and this is simply neovascular glaucoma in the stage of bleed, and a stage of total closure. So these are all qualitative things, just examples of how beautiful that small little thing in your hand is for a diagnosis of what is going on. It's not going forward. Yeah. So let's see what the experts say. So it's nice to have an AGIS consensus statement on angle closure glaucoma. And I quote, "Gonioscopy is indispensable to the diagnosis and management of all forms of glaucoma and as an integral part of the eye examination." So somebody with a diagnosis of glaucoma has an incomplete examination if you don't do gonioscopy. Anterior segment imaging devices may augment the evaluation of the anterior chamber angle, but their place in clinical practice still needs to be determined. So the slides are jumping. Okay. Now don't get me wrong. We love, at least I love the UBM as my newest tool on the box. It's indispensable in certain situations where gonioscopy does not have an answer. But it's not a replacement. It's a completely different thing. And they're both complementary to each other. So we started out with evaluating the anterior chamber angle in Asian Indian eyes because that's when we got the machine. And that's when the hype was that you could, dispense with gonioscopy and do this because it's objective, it gives you numbers, you can talk to the patient and all that and so forth. And we realized that the gonioscopy was just as good, if not better. So we didn't need the the UBM actually to tell us whether the angle was open and closed. Then we did UBM quantification of a change in anterior chamber angle. So we had no idea that question of when you have chronic angle closure glaucoma, should you do an LI, should you not do an LI? And there's no way that subjectively we could say, okay, this angle appears to be closed or appears to be open. So we used the UBM pre and post, and we realized that even in quadrants perpendicularly or 180 degrees away from where you did the LPI, the angle demonstrably increased. So it has a place even in chronic angle closure glaucoma, something which intuitively we had been doing anyway as a first procedure. Then we looked at occult intraocular foreign bodies. There was no way that we could have imaged it without the UBM. Then we looked at blebs to predict which ones are good for subtenons needling, and we've also written up a couple of reviews in various journals on the UBM. So we'll just, okay. So when we need to see areas hidden to us, the ciliary body and iris, there's no way a gonioscope is going to tell you, simply because it's hidden, isn't it? So it's analogous to saying whether you need to do fundus evaluation or you need to do ultrasound. I mean, there's no debate. If you can see the fundus, you don't need an ultrasound, but if you can't see the fundus, you need an ultrasound to tell you, by and large, whether it's okay or not. So the same thing with the UBM, it's an ultrasound. So if you can't see those areas, you need the UBM to tell us. So this was interesting. A young boy comes with acute angle closure in one eye with decreased vision and referred for laser iridotomy. So something tells you clinically that it's just not it. The whole lens iris diaphragm is moved forward, and it's only the UBM. There's no other investigation which can show you this large cleft of fluid in the supraciliary space, which is pushing the lens iris diaphragm forward. We knew we weren't dealing with a pupillary block, so we went ahead and put a drop of atropine, which he would have required, and we unearthed this big tubercular abscess in the posterior segment. So that's how we can use it. Another one repaired at our center, persistent inflammation, a rosette cataract, and this little thing here, nothing else seen on gonioscopy. But if you do a UBM, this hyperechoic thing with back shadows was actually a large foreign body, and a large foreign body was taken out easily by just teasing the iris because the UBM told us that there was something there. The other thing is when the cornea is white, analogous to the ultrasound. When the cornea is white, you want to know what your posterior segment is looking like, and you also, as a glaucoma person, want to know, especially in children, what your anterior chamber is like. So we started off with this, and this was a eureka moment when these white corneas in a newborn baby, we just put a UBM there, and to our horror, we actually saw nuclear cataracts, and the baby was rubella positive. So it prompted us to look at neonatal glaucoma more seriously, and we now know, because of this baby, that if you have a smaller corneal diameter and a smaller eye with glaucoma, look for rubella. And why that's important is otherwise you'd be missing auditory, you'd be missing cardiac defects, which the baby might be having. So the other thing, this is severe neonatal onset PCG, corneal edema, but you can see that the anterior chamber is largely okay. This sort of neonatal glaucoma probably would do well with your combined trab, and she did. If you have these clear areas in the center, think of Peters, sure enough, this large Descemet's defect, but it tells you since the anterior chamber is all right and the lens is behind, even this would probably do well. And sometimes you have this large Peters looking thing, but if you look at it, this is a huge corneal cleft in the baby's eye because of the edema and coalescence of all the fibers there, but she does have a little Descemet's defect here as well, and yet the anterior chamber is all right. So these are all just helping you and aiding you in making clinical diagnosis when you can't see it very much. So I think the gonioscopy and UBM remain indispensable tools if we understand that the cornea is clear and the AC is visible and you only need to see the angle. Please do your gonioscopy. If the cornea is opaque or the structures are hidden to the eye that you need to examine, please use the UBM. Thank you.
Thank you, Sushmita. That was indeed